So the plan for today is a little bit of the background, but most of the time I spend talking about the study trials, or it's one trial. There are three aspects to that. Talk a little bit about outcomes, and then the logistics. So guidance on the consent process, IMP management, sample collection, how we're following up, and various aspects of training. So just to give you the tiniest bit of background about the trial. It seems a long time ago now, but at the end of 2017, beginning of 2018, the HTA put out a commission call for trials in sepsis. They said they were willing to fund more than one trial. And so we actually came together as a big collaborative group with investigators from around the UK to answer a number of important questions in one trial. We thought this was the best way of answering these questions. And so we had 4 research questions, and that is, do rapid PCR-based microbiology diagnostics combined with procalcitonin improve outcomes and antibiotic stewardship compared to standard care in ICU patients with sepsis? And this is led by Paul Dark and Ronan McMullen. Then the second question, does conservative fluid therapy with active removal of fluid, i.e. what we're calling deresuscitation, improve outcomes in the same group of patients? And as you heard, that's led by John Silversides and Danny McCauley. And then the third aspect, in a high-risk subset of patients, which I'll explain, does GM-CSF compared to placebo improve outcomes? And that's led by Tony Rostrom and John Simpson in Newcastle. And then finally, as we always know with these effectiveness trials, we also need to know the cost effectiveness of these interventions. So we have a health economics analysis plan led by Richard Greaves in London School of Hygiene and Matt Stevenson in Sheffield. So overall, this study, we can describe it as a multi-center, pragmatic, multifactorial, open label, randomized trial with this embedded randomized double-blind placebo controlled trial. That's a long sentence, so I'll break it down and explain what the elements are. So this gives you the overall picture of the trial, and there's sort of 2 aspects to it. If you look at the top half, first of all, it's adult patients with sepsis staying 48 hours in the ICU, and the first bit around the diagnostics and the fluids is a factorial trial. So there's one of 4 treatment groups you could be allocated to. So the diagnostic arm versus standard antibiotics, the fluid management and deresuscitation versus standard fluid management. And you get randomized into one group of each, so 4 groups overall. So that's the factorial design, and that's the large population. And then in the subset of sicker patients that we also think are more immunosuppressed, the smaller group, these patients will be randomized to GM-CSF or placebo, a blinded drug. I'll go through all the details in a moment, but that gives you the overall structure of what the trial is. So what are the inclusion and exclusion criteria? Well, at the high level, they're sepsis patients. As I said, they're adult patients that are admitted to ICU due to suspected sepsis and expected to stay for at least 2 calendar days. Or as you sometimes see it written, typically in the Australian trials, they describe that as still expected to be in the ICU the day after tomorrow. So in other words, if you admit a patient today on Friday, if you think they'll still be there on Sunday, they're eligible under that criteria. So they're there for at least 2 calendar days. They should be receiving intravenous antibiotics for suspected sepsis. And that you should have completed that early initial fluid resuscitation before entry into the trial. So in other words, that first 3-hour sort of guidelines about giving fluids in that short period of time, that early resuscitation should have been completed. So very simple, hopefully pragmatic, includes most of the patients coming into the ICU with sepsis. We want to recruit them early into this aspect of the trial, because if we want to impact their fluid therapy and certainly the diagnostic, the antibiotic choices, we need to recruit them early. So they have to be recruited into this part of the trial within the first 24 hours of ICU admission. As you'll see, the GM-CSF component allows randomization a little bit later. It can be a second randomization. So it's 24 hours for this first part, the fluids and the diagnostic part. We want patients who are admitted for the first time to ICU for sepsis on this hospital admission. So we don't want the patients who keep coming back with recurrent sepsis. However, you could recruit a patient, say, who may have come to your ICU post-operatively after surgery. They had an elective stay, went to the ward, and then developed a pneumonia on the ward, and then now coming back in with sepsis because that's their first admission due to sepsis. That would be okay. We would exclude patients who are not expected to survive for 90 days due to their chronic existing diseases. So again, not because they're so sick that you don't think they'll survive 90 days, but if they have some long-standing chronic disease where you essentially think they're in a palliative pathway, we want to exclude those patients. And if you really don't think they're going to survive the first 24 hours because they're so sick, again, we would exclude those. We're excluding patients who are severely neutropenic, so less than 0.5, due to chemotherapy or malignancy, but not due to sepsis. So again, we're these patients who are immunosuppressed for other reasons, we're not including them. But otherwise, if there's immunosuppression due to sepsis, that's okay, they can be in. And again, anybody who needs a long course of antibiotics, so more than 21 days, we're saying, so guessing maybe the infective endocarditis, osteomyelitis, abscesses, tuberculosis, etc. These would be excluded because we're not going to be able to change their antibiotic course based on the biomarkers. And similarly, other patients who may have set fluid regimens, so DKA, HHS, diabetes insipidus, or subarachnoid hemorrhages, for instance, may have very different fluid needs, so they would be excluded. And if you've got a patient who's very small, under 40 kilos, they're excluded as well. So hopefully, as you see, although there's a few criteria, very pragmatic, we are looking for most all comers really to ICU with sepsis for the first time. As I mentioned, there are slightly different inclusion-exclusion criteria for the third part of the trial, the GM-CSF component. And for here, we are looking for a sicker group of patients so that they have to be mechanically ventilated, and expecting that for to continue for at least another 24 hours. Or alternatively, that they've got 2 organ support if they're not ventilated. Obviously, most of the patients will be ventilated and something else. But if you had patient on vasopressors and renal replacement therapy, they would be eligible as well. So we're looking for a sicker group of patients, a high-risk group of patients, and that they're showing signs of being immunosuppressed, which we know happens for many septic patients. And for this, we're using a simple criteria that's available in all our hospitals on a full blood count, is if the absolute lymphocyte count is less than 1.2 for 2 consecutive days on 2 consecutive samples. So in other words, you can't have any above 1.2 in between. And there's good sign that this simple measure is a good way of identifying an immune suppressed phenotype that you maybe would be able to test on more fancy tests, but unfortunately they're not available in all our hospitals. So we're using this to identify this immune suppressed group of patients. Now, as I mentioned, where if you look at the exclusion criteria, we realize that not all the patients will meet these criteria on admission to the ICU. And in fact, actually, we're expecting these patients to reveal themselves over time. It's this sicker group of patients who often will become immune suppressed after a couple of days in the ICU. So here, for the GM-CSF part of the trial, you can be recruited up to 5 days since the ICU admission. So we extend that window for this third intervention. And our other exclusion criteria for this are fairly straightforward. Obviously, if they're receiving either GM-CSF or G-CSF, they would be excluded. If they have a very high white cell count already, so the label of the drug says warnings about if the white cell count is above 50, they would be excluded. If they're obviously allergic to the drug or yeast products, which is part of the product, For this part of the trial, the GM-CSF bit only, pregnancy and lactating women would be an exclusion criteria. So we do need this tested with a urinary pregnancy test or blood, should you measure it. For the other parts of the trial, pregnancy is not an exclusion, but for this part, it is. We don't want to be giving pregnant patients GM-CSF. And similarly, if they've got an active hematological malignancy, so we've said that's defined as treated within the last 5 years, they're excluded, or if they've had either a solid organ or bone marrow transplantation. And for this part of the trial, if they're very large, over 125 kilos, they're excluded as well. So those are the summary of the inclusion-exclusion criteria, hopefully not too onerous, just taking out a few patients where we don't want to intervene, for instance. And you can see here, we've got a list of some of the trials where we've sorted out co-enrollment agreements. So hopefully it's helpful for you running multiple trials now, studies in ICU. It's okay for all observational studies. Remap cap for the flu interventions around steroids and antivirals is okay, but not for the antibiotics and macrolide, because that involves duration of antibiotics, and other immune modulation drugs and GM-CSF shouldn't go together. And similarly with the Infinite trial, we're testing interferon, they couldn't be randomized with the GM-CSF bit, but they could be randomized within the fluid and the diagnostic arms. March, Vitalize, T4P, Mosaic, they're all fine to co-enroll for all aspects. For those of you doing ADAPT sepsis, it obviously has only got a few more months to run. Again, you can't be in the antibiotic and the fluid arm, because the way the trial works is the fluid and antibiotic component has to go together. The GM-CSF bit can be separate. So you could randomize a patient in ADAPT sepsis to the GM-CSF intervention. That would be okay. They're excluded from traits. And again, other trials starting up at the moment, shorter, again, testing different duration of antibiotics. What we've agreed with Tony Rostron, who's running that trial, is that because we have different recruitment windows, both trials could run in the hospital at the same time. Because SepTiC has a 24-hour recruitment window to the antibiotic element, if you can recruit the patient within the first 24 hours, please put them in SepTiC. We understand you will undoubtedly miss some of these patients. Then they could be eligible for the shorter trial. And we think this is the best way of making sure both trials are able to deliver and exist in the same hospital. Obviously, you can't be co-enrolled in those aspects of the trial together. A bit like ADAPT sepsis, though, if you were in shorter, you could be in the GM-CSF component of SepTiC. So what actually happens in the different elements of the trial? Well, in the diagnostic trial, if you're in the treatment group, what we want you to do is send off the rapid PCR test. You send it to a central lab, is where it's being analyzed. It's called the SepTiC test. It's made by Moulsing, and there are 2 stages to it. The first bit is the look for a PCR product, i.e. can they find the bacterial DNA? And that result generally takes 24 hours. If they do detect the DNA, it then goes for sequencing and identify what the organism is, and that takes another 24 hours. We're also we're combining not only the microbiology testing, but also procalcitonin. And we think this is the best way of using these biomarkers in combination. And so we need 2 procalcitonins, one on the time of randomization, or if you've done it already before you randomize, because you may have it as part of clinical care, that sample, and then one the following day. And simplistically, just summarizing it, if the PCR is positive, if you get that result after the first 24 hours, and then subsequently we know what the sequencing result is, we will give you that information, and you work with your microbiology team to select the right antibiotics for that organism according to your local sensitivity resistance patterns. If, however, the PCR result is negative, which you'll find out that next day, look at the procalcitonin result. And that's both of these results. And we're saying if the PCR is negative and both of the PCTs are negative, or there's a big drop from day 1 to day 2, so a drop of more than 80% on that second sample, and that there's no clear other source of infection, so no other positive microbiology and nothing else on microbiology testing that would say there's infection, then we're saying that probably this patient hasn't actually got an infection, so please stop the antibiotics. So we've got both the microbiology test and the PCT are negative. I think this is good grounds for actually saying this patient doesn't have infection, stop the antibiotics. We put some guide on what that sort of clear evidence of infection might be. Obviously, if they had any other microbiology that's positive, antigen tests, if they've got a purpuric rash, or you've seen white cells on a lumbar puncture, or even fecal soiling at laparotomy. I mean, clearly these patients have an infection and they should carry on their antibiotics. But if they haven't, please stop them. Obviously, in all, because we're not specifying how long you give the antibiotics for in all of the cases, other than when we're asking you to stop. We try to keep antibiotic courses short. A little bit more detail about the PCR result. What will happen is if it's negative, you'll get this result sent to you, and it will say what I've summarized in that previous slide is we've detected no pathogens by PCR in the blood specimen. Look at your procalcitonin, and if both negative, please stop the antibiotics. If on that day 1 result you get back that the PCR is positive, it will say we've detected some DNA in the blood specimen. Continue your antibiotics according to your local guidelines, and more information will follow. What will follow on the next day is one of these 2 results, hopefully. It will say what the organism is that we've detected. And we sort of divided it into 2 lists, because this is actually quite sensitive and can pick up almost any bacteria. Many will obviously be pathogenic, but some may not be pathogenic. And so we've made a list of likely pathogenic organisms, which I'll just show you here. So if you, obviously you won't be able to read them all now, but these are the common organisms that cause infection and lead to sepsis in ICU. If we detect one of those, you'll get the first comment that Klebsiella was detected by PCR on bloodstream specimen, for instance. So that's what it will say. This is recognized as a cause of sepsis. Please speak with your local microbiologists to optimize the antibiotics for this organism. And that would say for any of those pathogenic bacteria, depending on whichever one you grow. So we want you to optimize your antibiotics based on that's the likely cause of the infection and sepsis. If it's another organism that's not on that list, then we've say a little bit more cautious. So this may be associated with sepsis in some circumstances. So this is a bit like when you get one of those contaminants in your blood culture bottles, coagulase negative staph, for instance. Is it really pathogenic? It's often unsure. So we're leaving you again to discuss with your microbiology team and actually decide whether you think this is the causative organism and you want to tailor your antibiotics to that, or if you think I don't think this is, then you decide. So it's essentially we're trying to use the PCR a bit like your blood culture results, but hopefully it's just more sensitive and it gives you more likely to give you a result which can help you, and you tailor your treatments accordingly. Obviously, if patients are in the standard care arm, they continue their antibiotics as normal. So follow your normal guidelines around antibiotic stewardship. Obviously, the guidelines would suggest you should review on a daily basis with your micro teams and de-escalate and short courses of antibiotics, as appropriate. So that's the diagnostic arm and the trial aspects. Move to the second bit, the conservative fluid and the de-resuscitation and the treatment group. What we're looking here, if the patient is randomized to this group, is they get a conservative fluid strategy as soon as possible after randomization. So they should already have been fluid resuscitated. by this stage, if you remember, that early resuscitation has been complete. And then we said that you only give fluid boluses if there's objective signs of hypovolemia, and we've defined those for you. So if you've got skin mottling beyond the area of the kneecap, so that sort of size of mottling, not just a little bit of a dusky toe, but a considerable area of skin mottling. If you can't maintain the blood pressure without going up on the noradrenaline a lot and you're struggling, obviously they may be underfilled and may need some fluid, so give a fluid bolus. If the lactate is above 3, or, and this is for day 1 only, if they're oliguric. And I think it's important to stress this is only on day 1. So if they've got this low urine output, less than 1/4 ml per kilo per hour. What we're trying to avoid is on day 2, 3, 4, 5, often junior docs will notice urine output dip overnight and pour loads of fluid in. That's what we're trying to avoid, not giving these patients excessive fluids. So if there are these overt signs of hypovolemia, give the fluid bolus and then reassess after the bolus. If there's been some improvement but not totally resolved, then of course you can give us more boluses if you need. If the criteria for the hypovolemia have gone away, stop. If there's continued no improvement after giving multiple boluses, we would still ask you to stop, say, after a litre and just reassess and see, well, actually, I'm giving this fluid. It's not helping. Do I really think more fluid is needed? So just to have a review then. We would ask that this group that gets no maintenance fluid, so no running 100, 125 mils an hour in the background, whatever. They can obviously get their normal feeding. And if they're losing fluid or blood from other places, you can replace that fluid as well. So to, just match those fluid losses or blood losses, etc. That's all okay. And then after that first day, we're asking you to, for the first up until day 5, assess for cardiovascular stability. If the patient is cardiovascularly stable, which we're defining as on a dose of noradrenaline less than 0.2 and that dose isn't going up, and if they have signs of fluid overload, which is a combination of either being fluid overloaded and signs of edema, wherever that may be, including looking at this chest x-ray, then once they're this, as long as they're cardiovascularly stable, we'll ask you to start the de-resuscitation, which means giving diuretics to aim for a fluid balance of around about a litre negative each day. And so to do that, we're asking you to give a once daily dose of indapamide or another thiazide diuretic, and to give frusemide. Give a bolus, 1/4 milligram per kilogram, and then start an infusion and just titrate it to aim for this litre negative over the day. If they're already on renal replacement therapy, or you need to start it rather than give diuretics, then just aim for the same negative balance through the fluid removal. And each day, just keep on reassessing. And once they're no longer edematous and the fluid balances would come back to neutral, then you would stop it. And obviously, this continues only for the first 5 days. And there's quite a lot there, but we've got a flow chart that will help you with that process. It's a bit small to see on the screen, so it's sort of enlarged it here, but showing you on day 1 guidance of what you should be doing, including the objective criteria of hypovolemia. And then from day 2 onwards, how you should manage that around the cardiovascular stability. And there's also a little troubleshooting box there, common problems that you might run into and guidance on how to address that. It may seem, as I said, a little bit complex there, but John Silversides has been run this successfully pilot in the radar trial, and I'm sure he will answer questions you might have about that, but it can be done, and we did see separation in the 2 groups between the trials. And as I said, this stops on day 5, or should they leave the ICU before that, you stop it. It only continues while in the ICU. The standard care is give your normal fluid boluses and maintenance fluid if that's what you do, standard drug dilutions. Patients, you can set their fluid balances as you feel appropriate. If you feel you need to give diuretics for a clear clinical indication, you can, but we would ask you, obviously, try not to just start following the treatment arm as your new standard of care. Try and stick with what you used to do rather than follow that. Otherwise, we'll see no separation in the two groups, and we're going to have to monitor as the trial goes on. And so then finally coming to the GM-CSF component of the trial, remember this is in that subset of patients that may be a second randomization. It may not be, they may not meet the criteria at that first instance, so you can recruit them to this part of the trial, randomize them rather to this part of the trial later. It's a blinded drug you give, so all patients will get the injections, which is weight-based for most patients. It's 2 vials of the IMP, which is given subcutaneously once a day for 8 days. If they're less than 50 kilos, you just reduce it to only 1 vial, so 250 mics of the active drug. It comes as a powder that needs to be reconstituted in the ICU. While it's being stored waiting for use, it needs to be refrigerated, so keep it in the fridge. But it's fine to be, once it's allocated to a patient, it can be kept at room temperature as the powder at the bed space, so that you can keep your box in the individual patient. We want to try and give it for 8 days is the maximum. If the patient is discharged from the ICU before that, we obviously think these sicker group of patients, we're expecting them, most of them, to stay for close to 8 days. But if they do get discharged from the ward before 8 days, if possible, can you give it on the ward? I know that's a real challenge. If you can't give it in the wards, it's not a protocol deviation. But if you can give it, we think that's better. There is some evidence that maybe if you stop it early when the patient recovers, they can rebound. So obviously we're trying to continue giving it on the ward, but I realize there are complexities about giving IMP in different places in the hospital, particularly if you don't work there. But we're hoping many of you will be able to find systems to make that work. Just to explain a little bit about how the drug will come, it's being over-labeled, so it's blinded in vials that come to you. We will be shipping initially to each site 8 boxes, so you get 4 lots of IMP and 4 placebo. And in each box there are 16 vials, so it's enough for every individual patient. And it will look something like this with the SepTiC labels on and so on. We'll talk a little bit about how we manage the reallocation to sites, etc. But obviously you can keep some up in the ICU, so you could allocate patients over a weekend, for instance. Just as a summary, in the protocol, you'll see the visit schedule that sort of tries to summarize it here about how we recruit patients. Obviously, at the beginning, do that screening for the fluids and diagnostic element of the trial. But as you see, patients can be randomized into the GM-CSF component up to 5 days after ICU admission. We are collecting samples, and again, sort of shown here the time points, and we can go through that in a bit more detail. And we follow up patients, and the way the CRF has been designed is sort of more information early on in those first few days. Particularly the first 5 days, looking at the fluid therapy that patients are getting and the fluid balances over 5 days. Then after the 5 days, the data collection reduces. We need information about antibiotics. And then we've got longer term follow-ups. 90 days is where our primary outcome is. We are doing quality of life and cognitive dysfunction at 6 months, which we'll ask you guys to do. And then the long-term 1-year follow-up is done via data linkage. And so just to illustrate that, our primary outcome is a combination of 90-day mortality, and we're looking at the clinical state of the patient over the 90 days. I'll explain that in a little bit more detail. Standard sort of secondary outcomes, length of organ supports and stay in hospital and ICU. We're looking what antibiotics are using, obviously important around the diagnostic arm. Does it improve antibiotic stewardship? But we need to know if patients are getting relapses or secondary infections. And as I mentioned, we are looking at long-term outcomes, health-related quality of life and cognitive function, and obviously the cost-effectiveness analyses. So just to explain in brief about our primary outcome, when speaking to our PPI group, they accepted obviously mortality is clearly very important, but they said we need to know more than whether we just patients live or die. So as well as improving survival, does it speed up their recovery? And so we have this clinical state where we look at the state of the patient. They can be in 4 different states, as you see, escalating in severity. So if actually I'll start at the bottom. The worst outcome to be in at any time is you've died. Then under that ICU with organ support, if you're showing signs of recovering, you may be in hospital, but you're off your organ support. And obviously the better outcome is to be discharged from home. So we will look at those 4 different states over the 90 days and hopefully see that patients, as well as reducing mortality rates, we can speed up their recovery and get them out of the ICU, out of hospital quicker. The sample size for the factorial trial is nearly 3,800 patients. So a large trial, but hopefully it's very pragmatic inclusion criteria. A lot of patients just coming into the ICU for 48 hours or more, randomized in that element. And we expect it will be about 1/3 of the patients will meet the stricter criteria eligible for the GMCSF. So that's aimed to be at 1,300. It is a big trial, but we think UK ICUs can do this with 60 centres. That actually only works out as 2 patients per ICU per month over a 3-year period. So I think that's very doable. Most of us are getting more patients than that a week with sepsis, I would suggest. So accepting we won't recruit all of them, but hopefully 2 patients per ICU per month is very doable. We do have an internal pilot at 8 months. So by next summer, we have to have shown the HTA, hopefully we can recruit to 350 patients. So I'm going to stop at that.
Okay, so moving on to the consent process. So if the patient has capacity, informed consent should always be obtained. If the patient does not have capacity, then we have the option for a personal legal representative, so which would be a family member or friend, a professional legal representative if the family member or friend is not available, and the pro-allow would be an independent doctor, so one who is not listed on the delegation log. We do have approval for deferred consent, so you can randomize the patient if you're not able to obtain consent and obtain consent later. And just a note there to say that the person who is taking the consent, so countersigning the form, should be listed on the delegation log. Retrospective consent. So if a patient regains capacity, please ensure that retrospective consent is obtained. If the patient is discharged from hospital prior to obtaining retrospective consent, then please contact the patient or family member. So the key here is to ensure that the patient or family member is aware of the study before discharge. So we want to ensure that any patient who is discharged early before we're able to speak to them is aware of their participation in the study. And then a note there just to say that ensure the participation of the patient is documented in the GP discharge letter, so the GP is aware. So IMP management, so Tony mentioned this earlier. So for the GMCSF trial of the study, we will be sending 8 kits to each site once you are activated. So this is the process of the IMP. So when your site is activated to this trial, we will send an order for 8 kits to the distributor. So the 8 boxes will include 16 vials per box. The IMP will then be delivered to your site. On arrival, the unblinded pharmacist, so we request an unblinded pharmacist at each site. This pharmacist will inform the database team that they have received stock and it's in sufficient order. The database team will then allocate 2 active and 2 placebo kits to be dispensed to ICU. The unblinded pharmacist will then log in to our subsequent database, so sealed envelope, and will dispense the kits to ICU, so that the kits that have already been selected by the database team. The inventory and accountability logs will then be updated, and once the ICU has 1 kit left, the ICU will then order more kits from pharmacy, and the unblinded pharmacist will then follow the same process. So we'll contact the database team to inform them we need more stock to be allocated. Further stock will be dispensed, And then once your site requires more stock, you will then order from the study team. So just a bit more about the unblinded pharmacist. So as I mentioned, each site will have at least one unblinded pharmacist. This person will then have access to sealed envelope, which will allow them to view all the unblinded kits. And the pharmacist will select the first 4 kits that are allocated by the database team that will be dispensed to ICU. So the idea is that when the kits are dispensed to ICU and utilized on ICU, we will always ensure that we replenish the kits like for like, which is why we need oversight of unblinding at the site. So the database team will allocate kits like for like, so IMP and placebo, and the unblinded pharmacist just checks that that's correct each time they dispense. So a bit about sample collection. So we are collecting samples as part of this study. Shall I answer questions now as we go, or I'll answer the questions at the end so that we can continue this recording. So when a patient is randomized, all patients will require the following samples to be collected. So we have a baseline sample collected, a baseline serum sample, a baseline DNA sample, and a baseline RNA sample. If a patient is randomized to a PCR test, then 10 ml of EDTA is collected for that PCR. If the patient is randomized to the GM-CSF arm, we require 3 additional samples. So an additional PAX gene sample taken at baseline, and then a PAX gene taken at day 3, and a PAX gene taken at day 5. So a bit about data collection. So our database is Open Clinica. This is part of the randomization and data collection. So the data, you will receive a login to randomize patients through Open Clinica and complete data entry. So the data entry forms include these forms here. So we've got baseline, which includes vital signs, infection and lab results, demography, co-enrollment, samples and consent. And then we have daily forms from day 1 to 28, where we're simply collecting any antibiotic changes, organ support, and whether the IMP was given. And then follow-up forms. So we've got the a day 90 follow-up form. So we ask that you'll complete it at day 95 in case the patient is randomized to GM-CSF, day 180 and 1 year. So the day 95 form is just requires survival, discharge and readmission. So you don't need to contact the patient. This can be obtained from medical records. Day 180, we request that you contact the patient and complete the questionnaires. So EQ5D and MOCA blind, which is the cognitive test. And follow up at 1 year. So that again is just survival, no contact needed, and can be obtained from medical records. So in terms of follow-up, we just require that you contact the patient at day 180. So that's 6 months. The database also collects as protocol deviations and serious adverse events. We will provide sites with a recruitment and follow-up tracker. So this acts as your recruitment log, screening and follow-up calculator. So we will request that all sites use this randomization log because it will generate your follow-up dates automatically. And just a little reminder there that at day 95, you don't need to contact the patient. You can obtain the follow-up information from medical records. Day 180, complete the questionnaires and do contact the patient. And 1 year, no need to contact, collect from medical records. So there's a 14-day window from each follow-up. So we want to ensure that the time point is within 14 days. Just a little follow-up here on the questionnaires. So as I mentioned, the patient must be contacted within 14 days of 180 for both questionnaires. There is some training to be completed for the MOCA blind for those that will be conducting that questionnaire. And for the EQ5D, 5L. So although I noticed a question in the chat there about whether the questionnaire is on the database, it is on the database. However, we do request that sites complete a questionnaire when on paper whilst they're discussing it with the patient to ensure that you follow the correct script and that that acts as our source data. A little bit about safety reporting. So due to the population of patients, we do expect AEs. So we are only collecting SAEs. Abnormal test results, again, due to the population, these are also expected, so not reported. For serious adverse events, the following events are captured as outcomes and so do not need to be reported as SAEs. So we have death, organ failure and support, a new infection, and C. diff, unless it's in the opinion of the local PI that this event was attributable to the study intervention IMP or protocol. So site training, so each site will receive an SIV. For Open Clinica users, we do have 2 options available. So if you require full access, so you'll be entering data, there's a module that needs to be completed online. If you're just randomizing, and we have a few slides for the randomization users to review and complete a training log. And for eligibility confirmation, we have a set of training slides for those that will just be confirming eligibility. And then we have mock blind training for those that will be completing the questionnaire, and study training logs. So at the moment, our training logs are paper, but we are hoping to move towards electronic training logs. All training materials will be available on our study website if you need any further information. And that's just a sort of a head there as to what the training would look like. Delegation log. So all staff listed on the delegation log must be GCP trained. So we do require a GCP certificate for those listed on the delegation log. For those that are required to be on the delegation log, we have a little summary here. So just a reminder there that the PI is ultimately responsible for those delegated any tasks in the study. If a person is obtaining consent from patients and family members, they do need to be listed on the delegation log. If a clinician is confirming eligibility, they do not necessarily need to be listed on the delegation log, but we do require that they have sufficient oversight. So we do have some eligibility training slides.
Oh, go on ahead. There's loads of it.
For the sites to follow.
That's fresh. Huh?
Okay. Unblinded pharmacists. So we do require the unblinded pharmacists to be listed on the delegation log. And IMP administrators. So those administering IMP, as long as they're sort of bedside nurses trained to administer medication, they do not need to be listed on the delegation log. So randomization users. So we do have the option to allocate users that have access just to randomization only. So they don't need to be listed on the delegation log, but should be listed on the clinical staff training log. So again, we have a log for those users. So we have oversight of who they are and the access they have. And we have some slides for them to follow, which just includes eligibility of the study and a few GCP principles. So for site activation, so we require a fully signed contract, completion of an SIV, protocol signature page by the PI, delegation log, signed and dated CVs and GCPs for those listed on the delegation log, localized copies of the consent forms and sample form, and normal lab ranges and accreditation certificates for the lab, and then staff training. So Open Clinica, mock blind, if completed by those that will be conducting those questionnaires, and CCC from the R&D, so local approval. We do have plenty of manuals available on our website. We are updating some of those at the moment. So we have a list here of the different training documents. So we've got completion guidelines, sample manual, fluid manual. They're quite detailed manuals. So we're hoping that it contains all the information that you need. Safety reporting, IMP management, randomization, and eligibility. And we also have some templates there for training. So just a little update as to where we are now. So at the moment, we are opening the diagnostic and fluid arms of the study. Next year, we hope that GMCSF will be open early next year. We will have some recruitment pauses over the year due to college closure days, just in terms of processing the samples, but we'll remind sites of those closure dates nearer the time. And also just to let you know that we are attending the UK CCRG in January. So we do have a session scheduled. So those of you that are attending, it'd be great to see you and discuss the study and let you know how we're getting on. And little overview of the team there. So this is our website and our email address and our team. So CI, managers, monitors, ops manager, and co-investigator.